The next general session presentation is about to begin. This session is entitled Medications for Epilepsy, Choices, Chances, and Changes. We're pleased to have as our speakers Dr. Rohit Marawar, an epileptologist with the DMC Harper University Hospital and one of our foundation professional advisors. We also have Dr. Kari Vavra James, a pharmacist with Ferris State University. So I know this is an important topic, so let's get started. Welcome.
Good morning, everyone. I'm Rohit Marawar. I'm an adult epilepsy specialist at Wayne State University and Detroit Medical Center. This is my first time here at an Epilepsy Foundation event, and I'm very excited to be here. I'm going to be talking about medications for epilepsy. Deciding on a medication for epilepsy is a very complex decision making that happens as you're talking to your physician, as you're telling him or her your seizure story. There's something going on in the physician's mind that makes them decide and put you on a medication which you finally decide on together. So these are some of the things I'm going to go over today about how does the physician make that decision, what are the chances that you're going to get success out of that medication, and when is it time to make further changes. So before we move on to the medications, I think it's very important to know a few things. The medications for epilepsy are actually medications for seizures. So as we know, pneumonia is a disorder, it's a disease, and fever and cough are the symptoms. Similarly, epilepsy is the disorder and seizures are the symptoms. Now, the reason why someone has epilepsy might be multiple. Somebody might have had a stroke, a brain injury, an infection. There might be many reasons, but that reason leads to epilepsy, which then leads to seizures. So the medications for epilepsy are actually preventing the seizures from occurring. They are not treating the underlying reason why someone has epilepsy. So this has made some specialists say that we should call these medications anti-seizure medications rather than anti-epilepsy medications. So it's like taking Tylenol for fever, but we unfortunately don't have the antibiotics which will cure the pneumonia or the epilepsy. So it's very important to make this distinction. Without going into the details, I think, as we all know, seizures are abnormal and excessive activity in the brain neurons. So there are two main mechanisms how medications work. One is that they prevent these neurons from getting excited, or if these neurons are getting excited, they quickly stop that excitation to spread everywhere else in the brain. The other way they can prevent seizures is by increasing the inhibition and preventing the excitation in the first place. What are the goals for medication use? We want you to not have any seizures. We do not want you to have any side effects with the least amount of medication possible. Now, obviously, these are ideal goals. Sometimes we are able to do it, sometimes we are not. Okay? Let's talk about choices. So, how many medications for seizures do you think we have? I would like to take an audience poll here. Who thinks less than 5? Raise your hands. Less than 5? 5 to 10? 10 to 20? More than 20? Oh, Wow. I don't think I've ever gotten that many correct answers to any of my questions. So we have more than 20 medications. So that's a lot of medications to choose from. I think besides painkillers and antibiotics, there is no single group with so many medications in that class. Now, when I discuss medications with the patient and we eventually start or we eventually decide on something, the number one question that I get is this the best medication? I want to be on the best medication. I think it's very important to realize that there is no such thing as the best medication. And this applies for a vast majority of people with seizures. There are certain exceptions to this, and I will get to that. There are certain pediatric epilepsy syndromes which have clearly some very good or the best medications and then some very good medications. But for a lot of people with seizures who have focal seizures, there is nothing like the single best medication. And moreover, we do not know who is going to respond to which medication. So essentially, when we are starting a medication, it is a trial. So something like childhood absence epilepsy. So we know that this clearly has a medication called ethosuximide, which is the best medication for it. So there is no other comparison to ethosuximide. Something like juvenile myoclonic epilepsy, we know that that valproic acid is the best medication for it, followed by lamotrigine and topiramate closely. But except these some couple of or few epilepsy syndromes, for a vast majority of people, there is no single best medication. So then the question is, how do we choose this medication? One of the most important things is to figure out if what you're having are focal seizures or generalized seizures and focal epilepsy or generalized epilepsy. And how does the physician know about that? Well, it's based on your seizure story. So when I'm talking to people with epilepsy or seizures, my patients tend to get annoyed with me a lot. And that is because I keep on asking them, what happened? How did it start? What happened during the seizure? How did it end? What were the symptoms after the seizure? Did you have any witnesses? And understandably, it's annoying to the patient because a lot of times they don't remember, and that's what happens with seizures. But it's important for the physician, for the neurologist, for the epilepsy specialist to get that story, because that is how we determine if the seizures that you're having are focal seizures or generalized seizures. As we all know, focal seizures is a seizure which starts in a small part of the brain and might or might not spread everywhere else, and a generalized seizure is what starts everywhere in the brain right away. There are some other things which might help us in figuring that out. EEG, brain MRI. These are some other tests that your physician will and should order to figure out if the seizures are focal or generalized. It's important to note that around half the time, around 50% of the time, these diagnostic tests will come back as normal and will not be helpful in making a decision. Okay. So focal versus generalized seizures or epilepsy, this is the first branch in this decision-making tree. Okay. There are some medications which you can only use for focal epilepsy, and I will name some of them. These are the older medications like phenytoin, carbamazepine, oxcarbazepine. So these are what we call narrow spectrum medications. If you use these in generalized seizures, they might not work, or worst case scenario, these might make the seizures worse. So it's important to know if you're having focal or generalized seizures. The next factor is, what are the other medical conditions that you have? Now, these might be medical, these might be neurological. We know headaches are very common. Migraines are very common. I get migraines all the time. If you're having migraines and you need to be on a medication for migraines, there are some seizure medications which we can use for both. So it's like killing two birds with one stone. There are medications like topiramate and valproic acid, which are excellent medications for migraine in addition to being excellent medications for seizures. If you get tingling in your hands and feet, you get numbness, you get burning pain, you might have neuropathy. And there are medications like gabapentin and pregabalin, which can be used for both neuropathy and for seizures. A lot of people with seizures have mood problems. They might have anxiety, depression, and there are some medications like lamotrigine, valproic acid, which are good for mood disorders. In fact, valproic acid is very commonly used by psychiatrists for bipolar disease. Conversely, there are some seizure medications which might make your mood worse. So these might make you more irritable, more angry. These might worsen your anxiety or depression. So these are one of the most commonly used medication, levetiracetam, can do all of these things. So it's important to know if you're having mood issues. Now, some seizure medications are metabolized by the body, specifically by the liver, and others by the kidney. And so it's important to know if you have a kidney problem or liver problem, you do not want to be on a medication that is metabolized by one of those organs. Next, if you are a man, doesn't matter, I think any medication will do, so men are not that important. But women, physicians are usually more careful when you have a female patient. So weight gain, weight loss, interaction with oral contraceptives. If it's a young female who is likely to get pregnant during the time of being on these medications, there are certain medications which have an increased risk to the baby. So these are all the considerations to think of before starting a medication. Specifically, one medication I want to point out is valproic acid. So this is usually in young females, we tend to prevent starting this medication because it can cause weight gain, it can cause polycystic ovary syndrome, and it has the highest risk of congenital birth defects, both physical and mental, if these female patients happen to get pregnant. Now, some of the older medications like phenytoin, carbamazepine, phenobarbital, valproic acid, we do not usually tend to start them in a patient who we are seeing in the office. But a lot of times, we see patients who have been on these medications for 10 years, 15 years, 30 years, 40 years. These medications do have long-term side effects, and some of them are vitamin D deficiency, which leads to thinning of the bones, making you more susceptible to fractures. Some of these medications can cause increased cholesterol, so you need more cholesterol medications, or it increases your risk of heart disease or stroke. So when we see people who have been on these medications for a while, then it's a difficult decision to make whether we should continue with these medications or whether these medications should be switched to another medication. If you are on any of these older generation medications, namely dilantin, which is also known as phenytoin, carbamazepine, phenobarbital, valproic acid, you should be taking vitamin D supplementation. Some of the seizure medications interact with each other. So if you are on 2 or more seizure medications, again, the older ones tend to interact more with the newer ones. The newer medications do not tend to interact with each other. What about the other medications? A commonly used medication like the blood thinner Coumadin or warfarin, it interacts with most of the older seizure medications. So these are the other, so we look at your medication list and then figure out what would be a medication that would not interact with these other medications. There is a big controversy amongst epilepsy specialists about brand name versus generic medications. To kind of give you a brief overview of these, brand name is what the pharmaceutical company comes up with once they start marketing the medication. Generic is being produced by different manufacturers. The FDA or the government decides that the generic medication needs to have 80 to 125% bioavailability of the brand name medication. What that basically means is you take a brand name pill, it produces a certain level in your body. You take a generic pill, it produces a certain level in your body. The level of the generic pill should be either 80% or 125% of the brand level. Okay? So that doesn't sound like a lot of variability, but in some people with seizures, even a slight change in their levels can lead to seizures. So it's important to know what you are taking. Are you taking brand name? Are you taking generic? Who is the manufacturer of the generic? Because a lot of times people get switched from generic to another generic, the same generic medication but made by another manufacturer. To address this issue, there were two very good recent studies for lamotrigine, or the brand name Lamictal, and they showed that the brand name Lamictal and generic lamotrigine has similar levels. And then when they compared two commonly known or two commonly used lamotrigine generic formulations, they also had similar levels. So I think at least for lamotrigine, we can say that brand name versus generic doesn't probably make a huge difference, but we cannot extrapolate this data to other medications. Some people don't like to take medications, obviously. Some people like to take medications only once a day. So this is another discussion to have with the patient is, if you want to take medication only once a day, then we need to start you on medication that you can take only once a day. Some people are already on medications which they are taking once a day, and so in that case, once a day medication is better. The very young and the very old have different bodies. They have different liver and kidney function, and so you have to take that into account when you are starting these medications. The very young, the kids might not want to swallow pills or cannot swallow pills. Older people might have difficulty swallowing, and in these people, then you might have to think about syrups. You might have to think about medication that can be crushed. You have to think about maybe a capsule which can be opened and sprinkled on food. So these are other things to think about in older and younger people. There is some evidence that older people who have memory problems, if they are on once a day medication, they are less likely to forget taking that medication. There is this concept called rational polypharmacy. As the name suggests, you can apply logic when you're taking more than one seizure medication. Basically means that if you combine two medications which have different mechanisms of action, you expect that the sum of this will be greater than its parts. But this doesn't really work out in real life, at least we haven't proved it. The only exception is lamotrigine and valproic acid combination. So I personally, in my practice, do not tend to pay a lot of attention to this aspect, but it's something worth considering. So we talked about which medication to start. How do we decide on the dose? So you always start with the lowest possible dose. You start at the low dose, and when I say low dose, the low therapeutic dose. You increase dose as needed for seizure freedom without causing side effects. You see if this seizure medication is going to interact with other medications, making its level too high or too low, and then you adjust the dose accordingly. As many of you know, that we tend to get blood levels for certain medications. Okay? I think a lot of physicians put a lot of importance on this blood levels. I think these should be used as a rough guide, these are not a replacement for what's happening with your seizures or your side effects. If you're having seizures, let's try to go up on the medications. If you're having side effects and no seizures, let's try to go down on the medication. The blood levels are a rough guide. Far too often I see patients in hospital or in clinic where the medication dose was adjusted purely based on the levels and not based on how the patient is doing from a seizure and side effect perspective. Okay. Moving on to chances. So how do I know that the medication is working? Okay. Well, if you're not having seizures, it's probably working. But when do you decide that? So if you are someone who has seizure once a month, and you are started on a new medication 2 weeks ago, we do not know if the medication is working or not. It's too soon. So what we tend to say is you need to go 2 to 3 times your inter-seizure interval before knowing if the medication is working or not. So if you're having seizure once a month, it will be 2 to 3 months before we know that this medication is working. What are the chances that I will respond to the medication? Okay. I think as we saw in the previous talk, around 50% will respond to the first medication, around 15% will respond to the second medication. So that's the good news. 2/3 people will respond to their first or second medication. The bad news is that 1/3 will not respond to any subsequent medication. So if you tried your third, fourth, fifth, sixth, seventh, eighth, ninth, 10th, or any combination thereof, the chance of being seizure-free is very, very, very low. So this is a chart I like to show in most of my talks because I think it's very illuminating. So this shows the number of seizure medications that we have had over the years. That's the blue line. The red line is how many people have been seizure-free over the years. As you see, over the last 20 years or so, we've had an explosion of anti-seizure medications. Okay? However, over the last 20 years or so again, the number of people who have responded to seizure medications has plateaued to around 70%, so 1/3 basically. So no matter how many medications we have, the number of people seizure-free are the same. So these newer medications have helped us that these medications are tolerated better because they tend to have less side effects and less interactions, but they have the same efficacy as older medications. So what are the chances that I will have side effects? Well, I mean, there's a large variability between different medications and what kind of side effects. But one thing to know is fatigue is the commonest side effect across all the medications. The second most commonest side effect across all medications is probably dizziness. If you're on multiple seizure medications or if you're on more than one medication in general, you're more likely to have side effects. It is important for you to communicate with your physician whether the side effects that you're having are tolerable or not. If you have a little bit of fatigue for an hour after you take your seizure medications, that might be acceptable to some, it might not be acceptable to other people. So that's why it's important for you to communicate with your physician whether the side effects are tolerable or not. So what are the options if you do not respond to medications, if you are within those 30% that do not respond to medication? Well, first and foremost, please see an epilepsy specialist or go to an epilepsy center to confirm 3 things. One is that you're indeed having seizures. Second is to confirm the type of epilepsy that you're having. And third, to confirm that the medications that have been tried are appropriate and they have been tried at appropriate doses. Another poll, can I take a poll? How long it takes for on an average, nationwide, how long does it take for a person with seizure to see an epilepsy specialist? Less than 5 years? Raise your hands. 5 to 10 years? Okay. 10 to 20 years? More than 20 years? Okay. The answer is the same as the number of medications. It takes more than 20 years for a patient with seizures to see an epilepsy specialist, and that's just too long. Imagine you're having chest pain for 20 years, again and again, and it takes you more than 20 years to see a cardiologist. So it's just too long. Yeah. So what are the options? We just heard in the talk before that surgery is an option, and surgery usually tends to give you the best chance for long-term seizure freedom. Okay. So you might be a good surgical candidate or you might not be a good surgical candidate. If surgery is off the table, or you might not want surgery. If surgery is off the table, then we have a couple of devices that can be helpful. VNS and RNS, commonly known as NeuroPace. VNS is a device which is put in the chest here, and a wire goes to the vagus nerve in the neck. RNS, the stimulator is placed under the skin on the skull, and the wires go inside the head onto the brain where the seizures are coming from. So both of these devices, they tend to produce stimulation. They lead to stimulation of the nerves or the brain, and for reasons that we don't fully understand, they can help with seizures. Important to know that while these can be helpful in some people, it's very unlikely that you're going to have seizure freedom with these devices. Ketogenic diet or modified Atkins diet can be very helpful in some people, especially kids. Probably if the medications are not working and if you're not a surgical candidate, this is probably the best solution especially in children. If you see an epilepsy specialist, usually they have a dietitian or a nutritionist who works with them, who can help you with the diet. This is the topic of the century, topic of the time. Medical marijuana, it's controversial. I just want to say, 2 words. One is a word of hope. I think it's exciting. I think we haven't seen the full potential yet. There are a lot of interesting studies going on, and we will have lots more information in the next 1 or 2 years. And also a word of caution is that we do not know what the long-term side effects will be, because nobody has done that study. So how can I, as a person with seizures, improve my chances of seizure freedom? Take your medications as you're supposed to. Probably the commonest reason we see somebody continue to have seizures is because they're not taking their medications as they are supposed to. Keep a seizure diary. That helps your physician immensely. And reach out to your physician if you experience seizures or side effects. I always tell my patients that please call me if you have seizures or side effects, and call me right away. Please do not wait until the next follow-up appointment, which might be 2 or 3 months away. A lot of times people come in and they tell me that, yeah, I had a seizure like the week after I saw you. So please call your physician right away if you have seizures, because then you can make adjustment to the medication right away and don't have to wait another 2 to 3 months to make any further adjustments. Okay, let's talk about changes. When do I make medication changes? So obviously, if you're still having seizures, you need to make medication changes. Either go up on the dose, or if you're already on the maximum dose, maybe you need to add another medication. It's important that we aim for seizure freedom, because even a 1 seizure can prevent you from driving. Even 1 seizure can cause injury. So the goal should always be seizure freedom. If you're having intolerable side effects, again, you need to contact your physician, because we want you to have a good quality of life. A lot of times we tend to concentrate on seizure freedom, but sometimes we forget that quality of life is important. It's of no use if you're seizure free, but you're walking around like a zombie. So quality of life, I would say, is even more important than seizure freedom. When do I make medication changes? So, we talked about when to start, when to change, but when do you stop medications? And there is no hard guideline on this, but most experts will agree that if you've been seizure-free for around 2 years, at least we can reassess the medication situation. Maybe it's time to stop the medications. Now, there are a lot of factors that decide whether the medication, it's safe to stop medication even after 2 years or not. So the good factors are that you're not having any auras, you have a generalized form of epilepsy, you have been seizure-free for many years, you needed only 1 medication for seizure control, you had only few seizures in your life, the time needed for initial seizure control was very short, and that your last EEG or the latest EEG was normal. Okay? So these are all the good factors, and the converse are all the bad factors. But it's very rare that we see a patient who has all the good factors or who has all the good factors. It's usually a mixture of these good and bad factors that we see in a patient. And that makes the decision very difficult about what is the likelihood that you're going to have a seizure if you stop the medication. I think it's a lot of this decision making by the physician is based on personal experience. It's based on instinct, and some of it is based on knowledge. One thing I would like to point out is a lot of physicians place importance on the results of your latest EEG as a guide to decide whether the medications should be stopped or not. I personally feel, and this is backed by some evidence, that that should not be the most important factor. It's one of the factors, but if you have all other good factors for stopping medications, and the only bad factor is an abnormal EEG, I don't think that's a big enough reason not to consider stopping. What happens if I have a seizure during medication reduction? So you've decided now that you want to stop, along with your physician, you decided that you want to stop taking the medication. The best way to stop taking the medication is to do it slowly over a few weeks or over a few months, because a lot of people tend to have withdrawal seizures because they're stopping the medication quickly. Okay? But let's say you decide that you want to stop the medication and you have a seizure. What happens to my driving? Do I have to stop driving for 6 months again? Do I have job restrictions again for 6 months? I don't think you need to. So, for example, if you decide to wean off medications and 1 month down the line you have a seizure, I personally would suggest that you go back on the medication to the dose that was working for you, and maybe for another few weeks, maybe a month or so, that you do not drive and you have job restrictions. I don't think we need to go back to that 6-month rule for not driving or job restrictions just because you had the seizure. In some ways, we have induced this seizure or provoked this seizure by taking you off the medication. Having said that, whenever I have a discussion with patients about stopping medication, the biggest obstacle to stopping medications is usually that they do not want to stop driving, which is completely understandable. If you're coming off the medication, your physician will ask you to stop driving for this few weeks that you're coming off the medication and for a few weeks afterwards. So it might take 1 month, 2 months, 3 months that you are not allowed to drive or you should not be driving. And that usually is the biggest obstacle for coming off the medication. I think I would like to end here. I hope you found this information useful. I hope that this will lead to a meaningful conversation with your physician the next time you see him or her. Thank you very much.
Good morning, everyone. I know lunch is just right around the corner, so I promise my part here is only about 10 to 15 minutes, and then hopefully you'll get to lunch because I'm sure everybody's getting hungry. My name is Kari Janes, and I'm a pharmacist. So my position is a little bit different as a pharmacist. I actually teach for Ferris State University College of Pharmacy, so meaning I spend a majority of my time actually training future pharmacists. But as part of my position, I also work in a hospital practicing as a pharmacist. So I may not be an expert when it comes to epilepsy, but I am a pharmacist, so I'm very well equipped to talk to you about the role of pharmacists in helping patients manage their medication regimens. So now when I say the word pharmacist to all of you, what's the first thing that comes to mind? Any volunteers? What was that? Busy? That'd be a good word. Other thoughts? Go ahead. Doesn't get meds on time, is that what you said? Yeah, go ahead. Yep, go ahead. Okay. Okay, so I heard a little bit about getting meds from the pharmacy and insurance and all the different costs kind of associated with medication. So all of those certainly, I think, can be valid. There's one in the back. Go ahead. So I like that one. Pharmacists can be an ally. So certainly that's what I'm here to talk to you about today. So generally I would say when I say the word pharmacist to someone, the first thought that really comes to mind is your local community pharmacist, right? So the pharmacist you encounter when you fill your prescription, so whether it be at CVS, Walgreens, Rite Aid, any of those pharmacies that are available out there. And usually the two biggest functions that we usually think about are dispensing and filling. And certainly those are true. That's an important function of what we do, but there's so much more that we can be of assistance with. So pharmacists practice in many different areas. So I already mentioned community pharmacy. That's one of the bigger areas. There are pharmacists such as myself who practice in hospital pharmacy. So if you've ever had to have been hospitalized, you may have encountered a pharmacist while you were in that hospital stay. We do have a variety of pharmacists that work in ambulatory care, meaning they practice actually in a physician's office, and they work kind of hand in hand with primary care providers to make decisions about medications. There are pharmacists who practice in academia, such as myself, so they actually teach for colleges of pharmacy. There are specialty areas, so infectious disease is a big area that comes to mind, pain management, oncology. Unfortunately, neurology is a smaller portion of where we have pharmacists specialized, but there are pharmacists out there that do that. And then managed care. So this would be pharmacists actually working with various insurance companies, and they help kind of make decisions about what meds get covered or make those decisions about approvals for patients. This is kind of just skimming the surface of where pharmacists practice. Certainly there are a lot of different areas above and beyond what I mentioned. So my message today is that pharmacists can help patients with epilepsy manage their medication. So I really like the word they can be an ally. That kind of goes along with my statement. So on this slide, I have listed a variety of functions that we can be of assistance with. And some of them do kind of overlap with what we already talked about a little bit before this, but that's okay. So kind of focusing on community and hospital, because those are the two main areas where you're probably going to encounter a pharmacist. Starting in the middle, both areas are well equipped to help with adherence. So I know it can be difficult to take medication, so I have a couple slides specifically looking at adherence after this one. So I'm gonna skip over adherence for right now. Dosing, certainly some of these medications can be very complicated to dose, so we can be of assistance if there are questions about that. We already talked about drug interactions, so especially our older medications, they interact with a lot of other medications. So as a pharmacist, we are always the ones screening, checking for those drug interactions, and if we see a problem, we're certainly going to consult the physician if we do have concerns about whether it's the epilepsy med that's going to be affected or if it's another med that's going to be affected. Education, so anytime you start a new medication, I'm hoping there's a pharmacist who's giving you education about that medication, what to expect, side effects. Above and beyond, you're also probably getting that from your physician. Profile review, so not just focusing on one med, but all of your medications as a whole. Does everything look okay? And then because medications do have side effects, unfortunately, we're always kind of looking out for those things as well if we have patients coming to us telling us what they're experiencing. Now, in the community pharmacy, they have a couple other unique areas that they might be able to assist with. So we already talked about kind of those brand, generic, manufacturer switch concerns. So if there ever is a concern about switching between like a brand and a generic name medication, one thing a provider can do is if they specifically want a brand name product, they can specifically say dispense as written or do not substitute on the prescription. So as a pharmacist, we are obligated to dispense that brand name product. And so if a patient gets established on a brand name product, generally the practice is to continue them on that brand name medication. Now the generic meds, it's a little bit more difficult because There can be so many different generic medications, and pharmacies stock different ones. So maybe these days drug shortages are such a concern, so perhaps we used to have one manufacturer at our pharmacy and then it went on shortage, so we had to get another one. So there may not be anything we can do about getting you that particular generic at the time, but certainly your pharmacist should be alerting you that your medication looks different and it is a different manufacturer, so that you know to watch out for potentially any breakthrough seizures. And if that does become a concern by switching to a different generic, certainly speak to your pharmacist or speak to your physician to make sure that we can get you that medication that we know works for you. So insurance was one thing that came up in talking about community pharmacy. So medications are expensive. They're incredibly expensive. Some of the older medications, not so much, but as we've gotten newer medications on the market, certainly those ones do have a cost associated with them. Your community pharmacists are going to be the one who are kind of handling those insurance issues on the front line. So when they go to fill your medication, they are going to be the ones getting that message from the insurance company saying, oh, this medication isn't covered, or potentially you have to try this medication first, or there's always that dreaded word, prior authorization, which just means it takes a little bit more paperwork to get your medication covered. So certainly I understand the frustration sometimes with going to the pharmacy and they tell you your medication isn't covered. But certainly that pharmacist can be of assistance to help you walk through that process. In the hospital, so pharmacists such as myself, we talked a little bit about drug level monitoring, so we can certainly be of assistance with interpreting those levels, especially if we have a patient with epilepsy come into the hospital. Maybe they're coming in for a reason other than their epilepsy. So we may not have a neurologist on board, we just have our internal medicine physician. If there is a pharmacist on that team, they do order a drug level, they can be of assistance with looking at those levels. Another common practice in the hospital, sometimes for whatever reason a patient isn't able to take oral medications at the time, so we need to switch it to something that can be given through a vein. And it's not always a direct one-to-one conversion. So pharmacists can be of assistance with making those switches back and forth between intravenous and oral medications. And because the kidney and the liver are very important, this is definitely something pharmacists watch out for. They're always looking at the function of those two organs, and they can make recommendations about adjusting medications based on those organ systems. So as I mentioned, adherence is kind of a big area where we can be of assistance. Who here has ever forgotten to take a dose of their medication? I'm guilty of this. Sometimes it's hard to remember to take them, right? And especially if you're taking multiple medications, it can get really complicated. Or if you're taking them 3-4 times a day, it can be very difficult. So it's especially more difficult if there are potentially memory issues to be concerned about. So epilepsy itself or the medications can potentially make those memory issues a little bit more difficult to remember to take medications. So this is where pharmacy can kind of be of assistance. I know my pharmacy, whenever it's time for me to refill a medication, I get an email or a phone call. So that's certainly one area that they can help you make sure to stay on top of your refills. There are a variety these days of smartphone apps. I don't know if anyone uses one of those for their medications, but there's a variety of them. I did a quick little search before I did this presentation, preparing it, just tons of options. Majority of them are free, but there are some that you do pay a small fee for depending on what you're looking for. And they all do similar functions. So they can basically give you an alert when it's time to take your dose, so you kind of set everything up in your phone. And then it just alerts at whatever time you need to take them. Or they also can alert you when it's time to refill meds. If you happen to miss a dose for any reason, you can track that on your phone as well, because that might be important for your doctor to know. If you missed a dose and then had a seizure, they would appreciate knowing that information. Also, pharmacists know about different formulations. So several of our seizure medications, they are available in kind of immediate release formulations, meaning they have to be taken potentially several times a day. And then there are some medications that are longer acting. They can be taken just once a day. So sometimes that's nice if you're on multiple medications to try and decrease the amount that you're taking in a day. Another concern is medication tolerability. So some medications, especially the newer ones, tend to be better tolerated than the older anti-epileptic medications. So certainly pharmacists are aware of all of those side effects and can be of assistance if side effects arise. We could also give suggestions on potentially how to minimize some of those more common side effects. Medication costs, like I said, this is always a concern. So in addition, kind of above and beyond all the insurance stuff, a lot of the drug manufacturers do have prescription assistance programs available. So I think many pharmacists are aware of this, and they can point you in the direction of where to look to see if there's an assistance program if you do have trouble affording your medication. And then certainly there are lower cost alternatives, so we can provide information about that, but of course, always speaking with your physician is important before you make any changes. Transportation can be a concern, just with the driving restrictions. It can be hard to get to your pharmacy to get your medications. So fortunately, some pharmacies do deliver, not all of them. I wish there were more, but some do deliver, which can make it easier. And then some pharmacies do allow you to sync your refills. So if you're on multiple medications and potentially they're running out at different times of the month, you can try and get them synced so that you just fill them one time, the same time every month. So it's saving you like a trip to the pharmacy every couple of weeks. You just go in once a month. Makes it a little bit more convenient. Patient perceptions can also be a concern. So anytime, a patient's on a medication, there might be questions about, how's it gonna work for me, or is it working for me? And then side effects. So certainly we can be one of those providers to talk to you about your concerns along with your physician. And then the inconvenient regimens. So this, especially I think about children, when they're younger, it may be very difficult for them to take tablets or capsules because some of them are just gosh darn so big. So there are a variety of syrups out there and solutions and liquids. It makes it a lot easier for children to take their medications. So certainly we can tell you what's available. And then we can help with a medication schedule to deal with those complex regimens, help you to time things out so everything is spaced out, easier to remember. So just to end here, pharmacists are very accessible. There are a variety of pharmacies that are open 24 hours and they are available on the weekends. So if ever your provider is not available during after hours and you really have like a burning question, call your pharmacist because they likely are going to be able to help you, or if they can't, they can direct you to the next best person. Pharmacists are very knowledgeable about medications, so as a pharmacist, I went to school for 4 years, so I spent 4 years just learning all about medications and how they work in the body. So certainly we know a lot about this certain area. And the pharmacists are trustworthy. I think I looked at the most recent poll. Nurses are number one in terms of most trustworthy, and then pharmacists are kind of right behind that. So I think most people feel fairly comfortable going to their pharmacist in the community and asking them questions. So just my takeaway point, again, I really like we can be an ally. So please feel free to ask us questions because we're always here to help. Thank you.
All right, great. We have a couple minutes to take some questions. Raise your hand and wait for the microphone to join you.
When talking about freedom from seizures, the percentage after taking one medicine, two medicines, three or more, are you saying like one medicine switching a different, or one or two on top of each other, or three at a time? Which combination?
Either.
Either?
So a total of 2 medications, either taking in combination or one at a time. It's the same thing. Yeah.
What is the best medicine for anxiety and anger added on to like your regular seizure medicines?
I think lamotrigine, valproic acid. These are two which are very commonly used, which can help with both anxiety, mood, and seizures. Recently, however, I read a meta-analysis and a systematic review for this very question, which actually showed, and this was completely new knowledge for me, is that pregabalin, or commonly known as Lyrica, actually it was found to be most effective for when people with seizures have anxiety issues. And this was a brand new information for me.
Likewise.
The question was, how much vitamin D do you recommend as a supplement?
So this is specifically for people who are on phenytoin, carbamazepine, phenobarbital, valproic acid, which can cause vitamin D deficiency. So whatever you get over the counter should be fine. What I forgot to mention is it should be a vitamin D and calcium combination, and not just vitamin D alone. I think the suggestion is 800 international units at least of vitamin D, and I forget how much calcium, but it should be a combination. And your physician should be checking your vitamin D levels, regularly, because if you are very, very low, then you might need a prescription strength vitamin D to at least bump you up to the normal level, and then you can continue taking the supplementation.
And just to add, there are a lot of supplements available over the counter that have calcium and vitamin D in them. Just double check to make sure how much of each is in there, because oftentimes there'll be more calcium than vitamin D, so you might need more of the vitamin D component.
Any suggestions on like how to tell the difference between like side effects like aggression and stuff like that with some medications versus your kid just being a toddler? I mean, how do you know when, like, yeah.
Good question. I think if you did not have it, if you did not snap, or if you did not have irritability or short-temperedness before you started taking the medication, then it's probably the medication. And usually, these side effects, like the irritability and such, they tend to happen pretty soon after you start taking the medication or after you increase the dose. Oh, okay. I think that's very difficult. I mean, if it's a new kind of a behavior, if you think her personality has changed right after you started giving her that medication, then it's more likely the medication. I mean, the good thing is, as we said, there are more than 20 medications. So if you are not sure, or if you're suspicious that it's causing a side effect, there are a lot of other options.
I was recently told that orally medicine doesn't get to you as quickly or as concentrated as rectal. I wonder if there's any medication coming that way. Any breakthroughs on that?
Yeah, from the pharmacy side of things, not that I'm aware of. I mean, that definitely is true. When you take a medication orally, it's going to take a lot longer to get into your system versus a rectal. So that's why often with kind of emergent situations where we're treating a seizure, they use the rectal formulation. I'm not aware of anything orally that's kind of coming out. There are medications, not necessarily anti-epileptics, but there are medications that dissolve under your tongue. So I don't know if there's anything in the works for that, but that would probably be what you would see maybe in the future.
Thanks.
I have two questions. The first is, I take a Synthroid tablet in the morning, and I've read that not to take calcium until 4 hours after you take Synthroid. That's my first question. The second is, I also take a D supplement in addition to calcium, because I've been told there's not enough D in the calcium supplement. And the D supplement that I found is like 2,000 IU. So I want to know if there's an adverse side effect to taking too much D.
So your first question, so the Synthroid and the calcium, certainly yes, those two can interact. We always recommend taking your Synthroid like first thing in the morning, a half hour before breakfast, because even food can affect the Synthroid absorption. So yeah, realistically, try and take your calcium at lunchtime or dinner, depending on how many times you take it. I would say at least 2 hours is probably decent. That's probably enough time. And then as far as the vitamin D, I would say 2,000 sounds pretty standard as far as what I see over the counter. Long term, I mean, I don't think there are many side effects to taking a little bit higher dose of vitamin D.
Yeah, I don't think there are any known long-term side effects from taking too much vitamin D.
And certainly if your provider is monitoring your level and you're getting to a level that's normal or potentially on the higher end of that, I would just consider backing off, seeing if you can find a supplement that has a little less in it. But side effect-wise, it should be okay.
Dr. Marawar, you mentioned diet and a change in diet as a possible choice to decrease seizures, but is there any research out there about a change in either physical fitness or activity levels to do the same?
There is some evidence that regular exercise, meditation is or mindfulness, both of those things have been shown to improve your seizures. Now, whether that's a direct effect or whether that's an indirect effect because it's affecting, it's helping you with your stress and anxiety and all those things, whether that's what's indirectly leading to improvement in seizures, we don't know. But I think both of those things should be helpful.
Why would we want to stop taking seizure medications even after 2 years of seizure-free? I don't understand that because as a mother, I'm tripping on that. Why? Why can't we just like, okay, you have it. What if we're driving now? 2 years later, bam, we have another seizure, and then we don't have a child. That overly concerns me. What do you think?
That's a good question. Some people, I mean, I think I'll answer your question by asking another question is why should you be on medications if you don't need it, right? I mean, that's what we want, right? We all of us want to be on as less medications as possible. So that's the reason why somebody would consider stopping a medication. The good thing about the newer medications, everything that has come out since maybe 2000 or something, is as far as we know, there are no long-term side effects from those medications. So if you are too afraid to have a seizure, I think it's completely reasonable if you want to continue taking them. With the older medications, there are long-term side effects, so you have to do the risk-benefit thing to decide.
Okay, we have time for one more. Last question.
Hi, I'm a mother of a 12-year-old girl who suffers from epilepsy. My concern is the benzos, the rescue meds. I think my biggest fear is addiction and or withdrawal symptoms. So I was hoping that you guys can address that.
Yeah, so certainly the benzodiazepines, medications that we use for rescue, when they are being used for conditions like anxiety or potentially depression, and they're being used on a consistent basis, we do start to get concerned about potentially addiction or tolerance. But when you're seeing it just used kind of intermittently as a rescue medication, I would say there's very, very low concern about addiction.
Well, thank you, Dr. Janes and Dr. Marawar, for being with us here today and sharing all of your expertise. I do have a little something for you to say thank you.